Hello. In this video, I'll be doing a deep dive on the core pulmonary exam with a demonstration of specific maneuvers, as well as a discussion of common pathologic findings and how to document those findings in the medical record. Consistent with this physical exam series, the core exam includes both screening maneuvers to detect asymptomatic disease, as well as general diagnostic maneuvers with an emphasis on those that are supported by evidence in the primary literature. There are separate videos demonstrating just the flow of the exam without any commentary, one demonstrating advanced diagnostic maneuvers that detect one specific pathology such as COPD, and one discussing and demonstrating archaic exam maneuvers which are no longer relevant in clinical medicine, but which may hold academic or historic interest. Jim will be helping us out today with our demonstration. The pulmonary exam is typically performed in the upright position. One might reasonably consider assessment of the respiratory rate and oxygen saturation as part of the pulmonary exam, though in most clinical scenarios, these will have already been measured by a nurse or medical assistant. In this series, I covered the assessment of the vital signs in a separate video. The core pulmonary exam really only has two components, inspection and auscultation, though these have many possible things to observe for. To start, observe the respiratory pattern. Despite frequent claims for a lower range than this, the best available evidence shows us that normal breathing occurs at a rate of 16 to 24 breaths per minute while awake, with a tidal volume of about 400 to 500 milliliters in adults, with an I to E ratio, meaning the ratio of time spent in inspiration to time spent in expiration, of about 1 to 2, and breaths are evenly spaced. Therefore, when considering abnormalities of the respiratory pattern, they can be either abnormal rate, abnormal depth, with an abnormal I to E ratio, or irregular. Obviously, many pathologies can impact the respiratory rate, including causing tachypnea, or an increased rate. However, a slow respiratory rate, known as bradypnea, should be treated as intoxication with alcohol, opiates, or other CNS depressants until proven otherwise. There are three general abnormalities of depth of breath. Breaths can be unusually shallow, which can be seen in many chronic and acute diseases, both of the lungs themselves, as well as the more general respiratory apparatus, such as neuromuscular disease. Unusually deep breaths are less common. While this can occur in primary pulmonary disorders, it is more classically a characteristic of respiratory compensation for the metabolic acidosis seen in an acute metabolic complication of diabetes called diabetic ketoacidosis. This phenomenon is known as Kussmaul respirations. This is an advanced sign of the disorder that was described by Dr. Kussmaul as, quote, perimortem, during the era prior to the availability of insulin. Luckily, with modern medicine, this condition is easily treatable. In Cheyne-Stokes breathing, there is a cyclical pattern to the tidal volume such that the breaths get deeper and deeper until a maximum is reached after a handful of breaths. Then the breaths get less and less deep until the patient has a period of apnea lasting 15 seconds or more, after which the cycle starts again. This finding is frequently missed or misinterpreted because you may need to watch the patient for a minute or longer to see the full pattern, but once observed, you'll realize how distinctive it is. However, despite its distinctiveness, in my experience, many clinicians misuse the term Cheyne-Stokes to mean a variety of other pathologic breathing patterns. The central component of its pathogenesis is thought to be increased sensitivity to carbon dioxide. It's seen in heart failure, a variety of neurologic disease, and in mountain climbers at high altitude. The only common abnormality with the I to E ratio is an exaggerated ratio. For example, obstructive lung disease such as COPD is associated with a ratio sometimes exceeding 1 to 3. And there are three forms of irregularity to remember. In biorespirations, the patient has normal and consistent depth, but the pattern is interrupted with random apneic periods. Biorespirations exist on a spectrum with ataxic respiration, in which, in addition to the random apneic periods, there is also a random irregularity to the depth of respiration. These are both seen in brainstem injury. Finally is agonal breathing, which consists of very slow, irregular, gasping breaths, which is usually a sign that death is minutes to seconds away in a patient with profound hypotension and/or bradycardia. Next, aside from the respiratory pattern, is there other visible evidence that the patient has respiratory compromise? For example, are they using so-called accessory muscles during respiration? The term accessory muscles refers to visible muscle activity with respiration aside from the diaphragm. This most often includes either contraction of the sternocleidomastoids and/or scalenes during inspiration, or contraction of the abdominal muscles during expiration. You may have already observed during the history if the patient was able to speak in complete sentences. Sometimes clinicians will use as a quasi-quantitative surrogate for respiratory distress the number of words they are able to speak with one breath, or how many words long their sentences are. For example, reporting that a patient is only able to speak in 2 to 3 word sentences is a helpful observation within the pulmonary exam, not from a diagnostic standpoint per se, but it's helpful to estimate how severe the patient's respiratory compromise might be. Patients with COPD may breathe with pursed lips, which generates positive end expiratory pressure and may improve gas exchange. Some patients with COPD are specifically taught to breathe like this, while others develop the practice instinctively and do so subconsciously. You may see the patient adopt an unusual position. For example, many patients with respiratory distress prefer to sit fully upright if physically able to do so. In addition, there is something called the tripod position, in which a patient is found sitting, leaning forward with their hands or forearms resting on their knees. Anecdotally, this is most typical of asthma and COPD exacerbations, though it's seen in a wide variety of other respiratory diseases. The reason some patients favor this position is not known. You may note a patient has what's called a barrel chest. A barrel chest is characterized by an increased antero-posterior diameter of the thoracic cavity, such that its axial cross-section appears relatively circular rather than more oval-like. Patients with barrel chests often also have kyphosis. It has a modest association with COPD, but can also be seen in patients without any lung disease at all, and it's not predictive of the degree of hyperinflation as measured by pulmonary function tests. There is one final abnormality to look for on inspection, which is clubbing. Clubbing is a painless enlargement of the terminal phalanges of the fingers and toes. When it occurs, it is most often symmetric. There are 2 practical definitions of clubbing. The first is referred to as an interphalangeal depth ratio greater than 1. This means that the depth of the distal phalanx at the base of the nail is greater than that at the distal interphalangeal joint. The second definition is a positive Shamroth sign. To identify the Shamroth sign, ask the patient to place the nail side of 2 fingers up against each other. There should be a very small diamond-shaped opening formed at the base of the nails. If there is no such window, the patient is said to have the sign and clubbing of those digits. An interesting historical side note is that Shamroth sign is unique as an eponym, as it refers to not only the first physician to formally describe it, but also the patient, as they were one in the same. Dr. Shamroth was a South African cardiologist who noted the development and subsequent resolution of the sign on himself during a bout of endocarditis. Etiologies of clubbing are many, but it is most commonly associated with pulmonary disease, including lung cancer, bronchiectasis, cystic fibrosis, end-stage pulmonary fibrosis, empyema, and lung abscess. Non-pulmonary causes include cyanotic congenital heart disease, which anecdotally leads to the most prominent examples of clubbing that I've ever seen. Also endocarditis, cirrhosis, it can be hereditary, and it can also be idiopathic. The mechanism of clubbing is not definitively known, but the most commonly cited hypothesis is the trapping of megakaryocytes and platelet clumps in the distal digits where they release growth factors stimulating proliferation of soft tissue. Given that no one hypothesis seems to be able to explain all associations, there may be more than one mechanism. Now, despite occasional claims to the contrary, it is not a simple direct consequence of chronic hypoxemia. Related to this misconception is a major point of disagreement on whether COPD alone can lead to clubbing. While some online resources list COPD among the possible etiologies, the most definitive references do not. Instead, if you were to see a patient with clubbing and COPD, your instinct should be to evaluate them for lung cancer. Before moving to auscultation, let's look at some of the evidence for inspection. Cheyne-Stokes breathing is probably one of the most underappreciated findings of heart failure. One study found it to be present in 1/3 of hospitalized patients with severely reduced EF, and that it had a high positive likelihood ratio for this. Regarding the barrel chest, this is very modestly helpful at diagnosing or ruling out COPD. That the positive likelihood ratio is an unimpressive 1.5 highlights the fact that many patients without COPD can develop a barrel chest. Pursed lip breathing has roughly similar type numbers for diagnosing COPD. And although clubbing is classically thought of as a sign of pulmonary disease, some of the best evidence for its diagnostic utility is as a sign of endocarditis and hepatopulmonary syndrome, the latter of which is a complication of cirrhosis. The remainder of the core pulmonary exam consists of lung auscultation, that is, placing your stethoscope on the patient's chest wall and listening to their breathing. For this maneuver, you should listen with your stethoscope's diaphragm, that is, the wider of the two sides, to the stethoscope head. Regarding the number and location of specific spots where you should listen, unlike cardiac auscultation, this is not standardized. I've seen references advocate for as low as 6 and as many as 28. Whatever number you choose will be somewhat arbitrary, but if I had to choose one number, I'd recommend 13 spots. To understand why, let's look at some anatomy. Remember that there are 3 lobes in the right lung and 2 lobes in the left. If we look at a person from behind, we can see that the paired scapula cover much of the upper thoracic cavity. Because the oblique fissure is, well, obliquely oriented, most of the left and right upper lobes, or superior lobes, are actually not directly adjacent to the posterior thoracic wall, and part of what is covered by the paired scapula. So we can listen posteriorly at 3 spots on each side, but this really only gets a good window for the lower or inferior lobes. Increasing the number of posterior auscultation locations doesn't help with that. Next, we listen at 2 spots in each mid-axillary line, one relatively high, which does listen more to the superior lobes, and one relatively low, which listens more to the inferior lobes. We then move to the front of the chest. Which parts of the lung were not well examined yet? Well, the apices, which are part of the superior lobes, were mostly blocked by the scapula, so we want to listen there. And we haven't yet listened to the relatively small right middle lobe, located lateral to the lower part of the sternum, which doesn't even border the posterior chest wall at all. This makes for 13 spots total. Now, let's see what this looks like on a patient. With a patient sitting upright, if you are not able to easily reach behind them because of the exam table, consider asking them to turn 90 degrees. Not only does this make auscultation a little easier, if the preceding history or if findings on auscultation warrant specialized pulmonary maneuvers, such as percussion or checking for a symmetric movement of the chest wall, these cannot be done properly while reaching around from the side of the patient. If you haven't already done so, ask if you can untie their gown at the neck, and then ask if the patient can place their hands on their opposite shoulders. This serves the double purpose of moving the scapula slightly out of the way for auscultation of the superior lobes, and more practically, it helps to prevent the gown from slipping off the shoulders. Have the patient take in a deep breath through their mouth each time they feel the stethoscope resting on their skin. Wait until exhalation is just about complete before moving to the next location. I recommend going side to side in order to compare the left and right. When you're going to listen in the mid-axillary line, you can have the patient place their hands on their hips to open up that space and make getting your stethoscope on the right location a little easier. When it's time to listen in the front of the chest, the approach deviates depending on whether or not the patient has breasts. For a patient without breasts, we can ask them to lower their gown to the waist. Listen in the 3 locations, and then either have them raise their gown back again or transition directly into the cardiac exam by lowering the head of the exam table or bed to 30 to 45 degrees. On the other hand, for a patient with breasts, while the gown is still up over their shoulders but untied, lower the head of the bed first and then ask them to lower their gown just to the level of the upper chest or a few inches below the clavicle. For the last auscultation location, have them raise the upper gown back to the shoulders and then raise the lower gown to just beneath the breasts while their body is covered with a sheet from the waist down. This is identical to the approach to gowning and draping that's done for the cardiovascular exam. During both posterior and anterior auscultation, while the back and chest is exposed, this is a good opportunity to additionally observe the patient's respiratory pattern and to ensure there's no accessory muscle use, since much of the accessory muscles were initially covered by the patient's gown. Now I'll discuss what you might hear while listening to the lungs. Sounds possibly heard during pulmonary auscultation are divided into breath sounds versus adventitious sounds. Breath sounds are those which are normally present, but which might have a different sound quality or be located in a different location than normal. Adventitious sounds are those whose presence at all is usually, though not always, pathologic. Let's focus on the breath sounds first. There are 2 main types, vesicular and bronchial. Vesicular breath sounds are what most clinicians typically think of as breath sounds. They are normally present in the lung periphery, like the bases, are relatively low-pitched, are more prominent on inspiration, and there's no pause between inspiratory and expiratory sounds. Laennec, the inventor of the stethoscope, compared it to the sound of leaves rustling in a gentle breeze. Bronchial breath sounds are normally heard over the manubrium, where the trachea is located. They are relatively high-pitched, expiration is more prominent than inspiration, and there is a gap between inspiratory and expiratory sounds. Bronchial sounds are sometimes described as sounding harsher or more hollow as compared to vesicular sounds. There are 2 major abnormalities of breath sounds. First is unusually soft or absent sounds. If unilateral, that could be due to a pleural effusion, pneumothorax, or collapse of a lobe or a whole lung. If bilateral, it's usually due to COPD, obesity, or shallow breathing. The second major abnormality of breath sounds is hearing bronchial breath sounds in the periphery, which is consistent with consolidated lung, for example, from a lobar pneumonia. Regarding adventitious sounds, the terminology used for them is confusing, inconsistent, and varies across the world. I'll use the terms here that are most commonly used by experts in the US. If you are from another country, there may be a preference for slightly different terms there. There are 4 primary adventitious sounds. The first are crackles. Crackles are brief, intermittent sounds predominantly heard during inspiration. They can be further subdivided into coarse or wet crackles versus fine or dry crackles. What are the differences between them? Coarse crackles have fewer per inspiration, are irregularly spaced, are of varying intensity, are relatively low-pitched, and are predominantly clustered in the first half of inspiration and are sometimes heard in expiration. I've heard it qualitatively described as like footsteps walking in deep snow, but I don't know if that quite captures it. These crackles are thought to originate from more proximal airways and are classically observed with pneumonia. Fine crackles have more individual crackles per inspiration, are regularly spaced, are of consistent intensity, and are relatively higher pitched. They either occur evenly throughout inspiration or are clustered in the second half, in which case they are known as, quote, late inspiratory crackles. The sound is often compared to that of rolling your hair through your fingers. Fine crackles are typical of interstitial lung disease. If crackles have an unusually fine character to them, they may be labeled Velcro-like crackles, which, if seen on a written assessment or board exam, should be interpreted as a buzzword for ILD. Heart failure and COPD can cause either coarse or fine crackles, or crackles with characteristics in between. An important note about crackles is that sometimes they are related to clinically insignificant airway secretions or mild atelectasis. This is particularly common in hospitalized patients who have been lying down and not taking in deep breaths for days. In this case, they will usually disappear after instructing the patient to cough several times. Once again, crackles that disappear with coughing are likely to not be clinically relevant. Another common adventitious sound is wheezing. Wheezes are continuous sounds predominantly heard during expiration that indicate airway obstruction or narrowing. Wheezes are sometimes subdivided into low versus high-pitched, or monophonic, meaning a single predominant frequency, versus polyphonic, meaning multiple frequencies. However, unlike the distinction between coarse versus fine crackles, these distinctions with wheezing are likely of minimal clinical significance. Common causes of wheezing include asthma and COPD, but typically only during exacerbations or attacks of those illnesses. Other causes are bronchitis and pneumonia. Particularly in young children, it can be observed in the aspiration of a foreign body. Heart failure can cause wheezing, which is occasionally known as cardiac asthma, a term I don't personally like since it is decidedly not a form of asthma. Incrementally less common but still important etiologies include anaphylaxis, bronchiectasis, and even pulmonary embolism. The other two adventitious sounds are uncommon. One is stridor, a continuous high-pitched sound typically loudest at the neck and upper mid-chest. It's often described as being predominantly during inspiration, though it can also be heard during expiration. It is strongly suggestive of upper airway obstruction and is a more common finding in young children. If the sound is loudest during inspiration, it suggests the obstruction is relatively proximal and extrathoracic, whereas if the sound is loudest during expiration, it suggests the obstruction is relatively distal and intrathoracic. Overall, etiologies include croup, epiglottitis, anaphylaxis, and aspiration of a foreign body too large to have made it lower than the upper trachea. Of all auscultation findings, heart or lung, hearing this one makes me the most nervous since it can suggest an impending airway emergency. The last notable sound is a pleural friction rub, usually shortened to just pleural rub. These are scratchy, crackle-like, non-musical sounds. Pleural rubs are caused by inflamed layers of the pleura rubbing against one another, as you can observe in pneumonia and in connective tissue diseases. They are usually associated with pleuritic chest pain. You may have noticed that there were several lung auscultation terms I have not yet mentioned. These are best avoided due to the unusually high frequency with which they are misused or misunderstood. For example, rhonchi. Rhonchi are best described as low-pitched wheezing that has a snoring quality rather than a musical one. In practice, though, the term rhonchi is often misused to describe gurgling sounds produced by air passing through mucus-filled bronchi. And there is also coarse breath sounds. While this term is frequently used on the wards, it's not mentioned in major physical exam textbooks and has virtually no mentions in the medical literature. Thus, it has no standard definition. It can be used to mean anything from a synonym for true rhonchi, to bronchial breath sounds in the periphery, to gurgling sounds from upper airway secretions. So I recommend not using it at all. Now I'll move on to the evidence for pulmonary auscultation. Well, there are many studies looking at a variety of findings in a variety of situations. Focusing on just the most commonly relevant, decreased breath sounds are modestly helpful at ruling in pneumonia, not so much ruling it out. The same goes for COPD. Bronchial breath sounds in the periphery are helpful for diagnosing pneumonia in patients with cough and fever, but their absence is not helpful in ruling it out. This is presumably because most pneumonias in the 21st century are not the classic, dense, lobar type of pneumonia that would be necessary to produce this finding. The presence of crackles in patients presenting to the ER with dyspnea is a little more helpful at ruling in acute decompensated heart failure than ruling it out. Same goes for crackles and suspected pneumonia, and wheezing and suspected COPD. To emphasize with wheezing and the negative likelihood ratio for COPD of just 0.8, it means that in a patient suspected of having chronic COPD, the absence of wheezing has minimal impact on the probability of that diagnosis. While it's my anecdotal experience that the presence or absence of wheezing is far more helpful at both ruling in and ruling out an acute exacerbation of COPD, I am unaware of any study which has directly evaluated that. A clinical peril about auscultation is that although adventitious sounds are sometimes described as always or fundamentally pathologic, they are present in a significant minority of seemingly healthy adults. And regarding the pulmonary exam as a whole, as you may have already noticed, the presence of abnormal findings are more helpful at ruling in diagnoses than the absence of abnormal findings are in ruling out diagnoses. I'm going to make one last point about lung auscultation as it compares to cardiac auscultation, a point which you don't hear people discuss as often as they should. With cardiac auscultation of extra heart sounds and of murmurs, with different timings and shapes and other characteristics, you can reason from first principles how certain sounds are created and what the acoustical characteristics tell you about the underlying physiology. You can overlay these sounds and murmurs onto something called a Wigger's diagram of intracardiac pressures, and for the most part, it makes sense. Lung auscultation isn't quite like that. It's just messy. There's not as clean a distinction as to which pathologies cause which sounds, and even references across textbooks and the medical literature can contradict one another on this. And the evidence behind a particular lung sound being indicative of a particular disease isn't as strong as it is for cardiac auscultation. I'm not saying that lung auscultation is worthless, because if it were, I would not have spent 20 minutes just discussing and demonstrating it. It's just that you should be more measured in how lung auscultation is incorporated into your clinical reasoning as compared to cardiac auscultation. I'll end with a discussion of how to document the pulmonary exam. The most concise documentation might only note the acronym CTAB for clear to auscultation bilaterally. However, if being more thorough, you should start with something like respiratory pattern and depth normal, no visible use of accessory muscles, patient speaking in full sentences, CTAB. Although one should assess for clubbing as part of the core pulmonary exam, and it would not be unreasonable to mention it here, it's more conventional to document the presence or absence of clubbing under a separate exam heading For extremities, where the presence or absence of edema may also be mentioned. That concludes the discussion of the core pulmonary exam. I'd like to thank Jim here for helping us out today. Also be sure to check out the core pulmonary exam without commentary to see the flow of maneuvers in practice, as well as another video that covers a few specialized maneuvers.